Mona. I'm an ophthalmologist and I've been with the PPCR for like many years now. And it's a very interesting topic, meta-analysis, and I'll try to make it as interesting and interactive as possible. And I'll try to make it as simple as possible so that you can understand it well. So I have no financial disclosures. So just to start, I hope you've had your cup of coffee. But when you look at literature, some studies which I saw showed that drinking coffee can actually increase the eye pressure. And I'm a glaucoma doctor. So other studies said it does nothing. And well, different studies had different results. So which one to believe, right? So that's how the concept of meta-analysis comes in. So the basic outline is that we'll first do the case discussion, then discuss the steps in conducting a meta-analysis. How do we extract and synthesize data? Then we'll do some exercises on data, forest plots and other graphs, and also subgroup analysis, right? So can someone start with the basic outline of the confusion and the decisions which have to be made in our case of the week? Anybody wants to contribute? Keiko, you want to ask somebody to just
anyone?
tell the challenges?
Yeah, maybe we can start with China side.
Yes.
Or maybe?
Yes.
Can you open your microphone?
Yes.
Okay, go ahead.
In this case study, In this case study, Professor Zhong need to access whether physiotherapy exercise after an elective unilateral total knee arthroplasty is effective, and he thinks the best way to do it is to perform a meta-analysis. And the problems for he and his team is to select one aspect as the main outcome and to know how to contain some articles to do a meta-analysis.
Okay, great. So I just want to know that he's a very experienced surgeon in his field. So why does he need to do a meta-analysis? He has so much experience. He believes in the rehabilitation following the knee surgery. Still, what is the need he feels that he has to do a meta-analysis?
I think he needs to get the support from the government.
Okay. But why would the government believe a meta-analysis and not him? He's a renowned doctor in his field, right? What is so special about the meta-analysis?
I think it's because the meta-analysis uses the statistical method, and it can analyze many studies to give a result, and actually p-values, so many people believe in it.
Yeah, that's right. So yeah, you did very well. So meta-analysis, as you can see, is at the top of the pyramid of the level of evidence, and it's very systematic and hopefully unbiased, and it's very objective. So that's why the government would prefer to believe that, and that's why we do so many meta-analysis, especially these days. The number of meta-analysis is increasing. So great. So anyone else would like to answer? Ziaho, why not a systematic review or a review of literature? What are the disadvantages?
Well, anyone from Japan? Jason?
Yes. Can I? Yeah. Actually, it's both review of literature and systematic review does review the past evidence, but not synthesize a single final result from them. So this is what the government and the professor wanted. So meta-analysis in this case is the best.
Yes, so a narrative review, maybe people may have their own opinions. They may not search all the studies, and from the same studies, different people may draw different conclusions. So that's why a narrative review is not preferred. Right, excellent. So what are the advantages of a meta-analysis? What is a meta-analysis, first of all, if you want to define it, and then what are the advantages?
Well, maybe Taeyang, Tian, can you respond to it?
Yeah, I'm here, and okay.
Good,
For just a second, I have prepared for this question, and
Great.
I'm now meta. So
So you want to define what is a meta-analysis?
I think I thought your question is the advantages and disadvantages of meta-analysis, right?
Yeah, yes. And you can, if you want, you can also tell me what it is, and then you
Okay.
can tell me the advantages and disadvantages.
Okay, so a meta-analysis is a statistical method for combining the results of different studies on the same topic, and it may resolve conflicts among studies. And meta-analysis is being used increasingly and plays an important role in medical research now. And a major advantage of meta-analysis is that it produces a precise estimate of the effect size with considerably increased statistical power, which is important when the power of the primary study is limited because of a small sample size. And a meta-analysis may yield conclusive results when individual studies are inconclusive. Furthermore, meta-analysis investigate the source of variation and different effects among subgroups. In summary, a meta-analysis is an objective quantitative method and provides less biased estimates on a specific topic. But it also has some disadvantages such as methodological bias, because it only choose research with positive results are more likely to be published, and research with with no results probably will not be published. And sometimes meta-analysis only use the effect size to summarize the research results in the whole field, which may miss a lot of valuable information. And I'm sorry, I have to check how the I don't know how to read this word. Heterogeneity. Yeah, and the heterogeneity of different researchers' methods and properties may make the different researchers hard to compare, and that's all.
Okay, great. That was very well put. Very nice. So, as I said earlier, a review of literature has no standard format, and there's no specific research question, and it cannot be replicated and can have bias. And a meta-analysis, as you said, is an analysis of analysis, where we statistically analyze a large collection of studies from an individual study. And first, we have to do a systematic review. And if the results are combinable, we go ahead and do a meta-analysis, right? So this is just an example I want to show where this was a review which combined, which talked about the combined effect of phacoemulsification with another procedure, endoscopic cyclophotocoagulation, and said that it was a good alternative to the existing one. But when a meta-analysis was done, it was found that there was no good evidence to support that the new procedure was better. So, and as you very rightly put, what a meta-analysis gives us is power, because we are combining all the sample of all the other studies, precision. Plus, we can also analyze multiple outcomes. For example, in an RCT, we have only one primary outcome or at the most two, but here we can look at multiple outcomes. It also has more external validity. You can explore heterogeneity, and we also can come to know whether we need more studies or not, right? So anybody wants to interpret this forest plots? Just a basic outline of the forest plots. Keiko,
Yes.
you want to
Anyone?
nominate anybody?
Maybe I can find someone
Could
from.
I answer? Maybe?
Of course, sure.
Okay. Okay, great. So basically here we have two different meta-analysis, and basically each of one of those lines, those small lines with the dot, represent the confidence intervals, and we can see how the small dots represent also the means. We can see how individually some studies, like for example in the case of the left, most of the studies are not very conclusive, or they can actually have one bias perspective or of the results. For example, we can consider that there are some studies in the left case that they would confirm that there is that favors the treatments, while in the other case favors the controls. If we take all these studies at the same time and we compare them and we analyze them in a whole, it's going to be for us easier to see that there's not a very clear tendency. While in the other case, in the case of the right, we can see how with among all the other studies, there is a much more clear tendency to favor the treatment.
Yes. So
I don't know if I explained myself very well.
Yeah, you explained it well, but what is the image on the right? Are they the same type of meta-analysis, or is there a little difference?
Okay.
The one on the right?
It's a, can I speak?
Yeah, for sure.
It's a cumulative one, so I think they use the same studies, but they used a different method, and the results were completely different. Is it?
Well, it's a cumulative meta-analysis. You're right. So and the other one is on individual RCTs. So if you can see, the RCT started in around 1972, and the first one had wide confidence intervals, only 77 patients. And then they kept doing the RCTs with no conclusive result, because you can see most of the confidence intervals are crossing the line of 1, and it's an odds ratio. So 1 means no effect. So till about 1980, they didn't come to any conclusive result. So they kept doing more and more randomized controlled trials. Now, if we do a cumulative meta-analysis of the same trials, like one, you can see the sample is getting added. So it is 77, then 230, whereas there 77, then the next trial is added, so 307, then 162 is added, it becomes 469. So as you can see that here by around 1981-82, we know that the treatment is effective, because the effect sizes towards the favors treatment and the confidence intervals are not crossing 1. So if we had done a cumulative meta-analysis, we would have had the answer by around 1980-82 that yes, the treatment is effective. And after that, what is happening is the effect size is not changing much, only the confidence intervals are decreasing. So whereas if we're doing individual RCTs, you can see how many extra patients have been randomized. So this is by approximately 6,000 something patients, we have the answer that yes, the treatment is effective. Whereas to get to the, even in 1988, we are not sure until we do a meta-analysis, and we have about at least 15,000 extra patients we have like randomized to these trials. So cumulative meta-analysis helps us give the answer earlier. Like we really can then think that, yes, we don't need to do any more RCTs on this topic, right? So that's another advantage of this, is another form of meta-analysis. I hope you could understand.
Yeah, that's very interesting. Just one doubt. On the left side, the left panel, it was not a meta-analysis. It was just plotting separately each randomized control trial, or it's another way?
Yes.
That's
No,
my
this is
doubt.
how we do a meta-analysis. We select the RCTs and then we produce a combined overall effect, which is given at the bottom overall. And you can see that it's kind of a diamond with a small line in the center. So the effect of all these RCTs, single studies, is pooled to get one effect, which is at the bottom. Whereas in a cumulative meta-analysis, each study keeps getting added to the previous meta-analysis.
So it's significant in the left.
Kind of
it's already
yeah.
significant. Okay.
It's a different way of, here you don't have individual RCTs. For example, the second line on top, that will have two meta-analysis. The first is the RCT. The second will have two RCTs. And then as the meta-analysis keeps on adding, the new RCT keeps getting added on to the previous meta-analysis, and then we get the answer.
So every time you have the p-value on the right is a new meta-analysis, is a new run.
Yeah, it keeps adding on each other. We'll do it in Stata also towards the end, then maybe you can understand. So it's not individual studies alone, it's a meta-analysis combined like with the previous ones.
So
right?
we are missing the years in the second column. So this study that was doing with 20,000 patients was not in 1988. That was the later exam.
No, the patients are adding up. That's what I'm trying to say. If you see the first 1972, 77 in both.
I see.
Then 230, whereas 307 is 307 plus 70, 230 plus 77. So the patients are going on adding up here. Whereas there are individual studies alone and then they are added up, right?
Hello, Mona,
you can see the numbers getting added. Yeah.
Is this method of cumulative meta-analysis usually done after the individual analysis?
No, once we have done some meta-analysis, we usually do cumulative meta-analysis to see whether we need to do more studies or not. Because here we know that by 1982, we know that we won't get better results even if we do more RCTs. If we keep doing individual RCTs, and then here the meta-analysis was done in 1988.
So usually, usually in a meta-analysis, first we perform individual analysis, and then we perform a cumulative method.
Cumulative can be done on a retrospect if you want to do it, just to know whether whether we need to do more studies on this, especially if you're getting effect which is like if you see in see, these are all individual RCTs. You see, 1972 one study, then 70. Like I'm suppose I want to do a meta-analysis today, so I collect the studies done from suppose 1972 till now, right? So they're all individual RCTs, and then I take each of them and plot them. So they will be the ones from 1972 down to 2020, and then today I'm adding them up. Before, they've never been added. The effect has never been pooled. Whereas here, what happens is, as soon as a new study is done, a meta-analysis done, then when the next RCT is done, it is added on to the previous one. You can see the numbers of patients adding up, right? So this obviously is done on retrospect, but it gives a better confidence interval and a precision, and tells us that when do we need to stop doing more RCTs on this topic. I hope I'm clear.
Okay, thank you.
Both are done on retrospect, of course, but this is a methodology which gives us good precision.
Thank you, Mona. It was very clear. Just one question more. when you do a cumulative analysis, you use the result from the previous one, or you gather all the raw data from the beginning to not to
We will do it in Stata
replicate the
towards
mistakes?
we will do it in Stata towards the end, then you'll
Okay.
see.
Thank
Okay.
you.
We have an exercise on that, right? Yeah. Okay. So my slides are stuck. My slides are stuck. 1 second. Okay. Okay. So yes, who will use a meta? It's very important to know who uses a meta-analysis, because you should always know who is going to read and utilize your study when you're doing a meta-analysis. So who are the usual people who will use it? Somebody wants to answer?
Anyone?
Keiko, you want to?
Any volunteer? Maybe anyone from China anyway? Today I can't find too many people from Japan. But
Somehow the participants are not. Yeah.
I can speak now.
anyone
Should I ask? Otherwise, I'll ask.
Can you hear me?
talking now? Yes, yes.
Oh, yes. Sorry. I'm gone.
Okay.
Hi.
Oh, okay. Sorry. You can
Yes.
talk. Okay, go
Okay.
ahead.
Who uses meta analysis? This is mean maybe like clinical research and some clinical physician and who want to find a answer from the clinical, so he will find this meta-analysis, and the clinical research also, and I think some patient will also read this, will also use this.
And in context to our case, who wants the meta-analysis there in the case of the week?
Pardon? I'm sorry.
In our case study, who has asked for a meta-analysis?
I'm sorry.
Can I?
Okay.
I think.
Yes, please. Yeah.
I think the government
Yes.
sometimes uses for policies, for determining policies for them.
Yes.
So
you're
not
right.
physicians or not people from health care.
So many people will use it, policymakers, patients. If somebody wants to donate somebody
think
to,
that is
for a
professor.
trial. Yeah.
I think that's professor.
Yeah. So he's doing it for the government, right?
Yeah.
Yes.
Okay,
Can you
go ahead.
see my slides? Can you see my slides?
Yes. Yes. Yes, we can.
I hope. Okay. Nothing's blocking it, right? Okay. So who conducts a meta-analysis are authors. Sometimes the government asks the meta-analysis to be done, policymakers, the Cochrane collaboration, even the industry, right? And who use a meta-analysis? Clinicians, researchers, healthcare givers, policymakers, patients, and basically it's the highest level of evidence in the pyramid of evidence-based medicine, right? So this is just an example. This came on the Time magazine based on a meta-analysis which was done, which said that eating butter did not have coronary risk, and it was based on this meta-analysis, and there was a lot of controversy. Had a lot of hype about it, saying butter is back. And when again people looked at it critically, the meta-analysis, they found that there were issues with the meta-analysis related to bias and maybe some wrong entries in the data and other mistakes. And so this just highlights how wrong meta-analysis can, wrongly influence policies, public. The reason I put these slides here is that once you're doing a meta-analysis, you might think it's easy, that you have to just aggregate the studies and put them together. But if you aggregate weak, low-quality research, the outcomes will not make great evidence. And when you have the power to do a meta-analysis, you have the responsibility to do it correctly, because as we just saw, it's being used by very important people like policymakers, patients, people who donate, industry. So just highlighting the importance of doing it very meticulously, right? So I think in the lecture yesterday, Professor Felipe discussed that it may take even a year to do a meta-analysis. You have to do it so meticulously, right? So anybody wants to tell the steps of meta-analysis very quickly?
Well, anyone? It's quite challenging question. Maybe anyone from chat?
Yes, I'll just open up the participants.
Can you?
Yeah, 1 second. Should I go alphabetically? Carla? Carla, you're there?
Sorry, can I talk? This is Fatima.
Please.
Hi. Please.
Can you hear me?
Yes.
Oh, hi. This is Fatima from group 2. So basically, we have 3 steps that consist for preparation, conducting, and reporting. And each one can be split up in different steps that actually I don't know. Like, that's what I got from Dr. Frenny last lesson, the 3 main steps that we might consider. And during the preparation of the study, we need to focus on the searching, like good searching to avoid bias, because from the beginning we can carry bias to our studies, and like then the conducting during conducting the study, we need to be focused on the methodology, and then the reporting, right? So I'm not sure, I'm sorry, I don't have every step because it's really complicated to memorize it, but I just...
We will make it very simple, don't worry. So if you have you're doing the group project, right? Are you doing the group project? Yeah?
Yeah, I do.
Yeah, so what was the first step in that? That you must be remembering, it's been done very recently. So what was the first step in your group project?
Establish your question. Establish what are you looking for.
Okay, so just stop there. So what is the question in our case of the day? Case of the week, sorry. What is the research question here? You read the case, right?
Yeah. It's like professor is trying to look for if exercise helps osteoarthritis. I'm not sure. I'm sorry.
Right. Okay. So any question has to be first of all, there has to be a gap, a need for the study, right? That's what you did for your group project, isn't it? There had to be a gap in literature. That's why you want to do a new study, right? If it's already there, you wouldn't be doing it. Okay,
Yeah.
that is first. Second, so now you have decided, okay, there's this gap in literature, and this is this is my research question. Any research question, either an RCT or a meta-analysis, has to be in a PCOT format. So what is the PCOT format?
The PCOT from the last case.
Yeah.
Okay. Population. It's a good enough. I mean, I don't have an exact number, but it's around 2,000. I'm sorry. The intervention in this case is exercise and control patients without exercise and
outcome.
The outcome gonna be like the score. I'm sorry, I don't know how exactly what is the score.
Okay, you can make your own outcome. Don't worry. Okay, so once you have your research question in your group project, say, then in this case, what do you do different? Here, what is your population here? Is it people? What is your study population here? Is it like patients? Will you recruit patients in a meta-analysis?
In the meta-analysis,
is it patients? Will you call patients for the meta-analysis?
You recruit studies.
Yes, here it's studies. So you look for the studies, right? So after the research question, you look for studies. So if whenever you're looking for somebody, you have to have a inclusion and an exclusion criteria, right?
Yeah.
Again, you'll have a inclusion and exclusion criteria. So once you have the criteria, you will look for studies. That is how will you look for studies? Where will you look? You have to think that. Then once you get the studies, you'll get the data. Then you'll combine the data and then you'll write your paper. Simple. Right. So you have a gap. You have a gap in literature. So you have a research question in the PCOT format. So your population here, you have to remember, is studies. Then you have to have established an inclusion-exclusion criteria that these are the studies I'm going to look for and these I'm going to exclude. Then you're going to look for those studies. You're going to read them up, choose which fit into your criteria. Then you're going to take the data from them, combine it, get the effect size of all the studies pooled into one, and then report it and write your paper and publish it, right? Okay, yeah. So that's a basic simplified outline. Okay, so we'll see what happens next. Okay, somehow my slides are, yeah. Okay, so as we discussed research question, I'm sure you all designed your group project and spend a lot of time discussing the research question. So I don't have to tell you this, that you really need to think hard and then have a research question. And I think you've already told me the PCOs for the research question for the case. So what about this? Can you read the text on my slides? I hope nothing's covering it. That's what I'm concerned because. So who wants to volunteer? Stefano? So what's the PCOs for this paragraph? Just take a second to read it. And what is the population here?
Mona, who did you call?
So Stefano.
Oh, Stefano.
Ready?
I'm not sure. Maybe
okay.
Some people cannot use mic.
Sarah.
Maybe.
Okay. I can't. I'll scroll the chat. Someone from China wants to try?
Well, maybe
Maybe can I try, because I messed up the last case, I'm sorry. I'm
No,
Fatima
you
again.
please try. Please do.
Okay.
I'm happy.
The patients here are patients with, the population are patients with coronary heart disease. And,
Wait. Are they patients? Are they patients? Read the first sentence very carefully.
Oh, yeah, okay. And then the intervention.
No. What is the population? What is the population?
Sorry?
What is the population?
The population is the studies, right? The randomized control trials.
Yeah. Which studies? Yeah. With which randomized control trials?
The ones, yeah, that included patients with coronary heart disease who had, who had a myocardial infarction, coronary artery bypass, percutaneous coronary intervention.
More than 6 months follow-up.
Yeah.
More than 6 months follow-up, right?
Mm-hmm.
Okay. Yeah. And then what was the intervention? What was the intervention here?
Supervised or unsupervised exercise program, right?
Yeah, you said that.
Sorry, I mean, yes.
Hi. Hi. Yeah. So it's the exercise program, right?
Yes.
And what was the control group?
Psychosocial educational interventions.
Pardon?
Psychosocial interventions, like comprehensive cardiac rehabilitation.
Can I say?
That was part of the, yeah, please do.
People who didn't have any kind of structured exercise training.
Yes, correct. So the comparator here was not one, but many. It could be exercise alone. The intervention here was like it's not just one type of intervention. It could be exercise alone or in combination with psychosocial or educational interventions. So it was like not just one thing. And whereas the comparator, as you said correctly, was no structured exercise and standard drug therapy, right? What was the outcome?
Mortality. Cardiac mortality.
Yeah, and
non-fatal myocardial infarction.
Modifiable cardiac risk factor and the health-related quality of life.
Mm-hmm.
It was a composite outcome, right?
And yeah, so if you see there are multiple outcomes, so you can analyze multiple outcomes in a meta-analysis, right? So what kind of a research question is this, broad or narrow?
Very broad.
Yeah, it's very broad, very good. Yeah, so there are two types of research questions. What is the advantage of a broad question and disadvantage? How do they compare a narrow and a broad research question?
Hi, broad can be more generalizable to the population. And the more you narrow it, the more specific it'll be less generalizable.
Yes. And when you do the literature search, in which one will you get more studies?
Sorry, can you repeat the question?
Yeah, so when you are searching for the studies done on this topic, so you will end up like when you do a PubMed search or you search Medline, in which one will you get more studies as in the search output? So
when
now
you
this is
when you have a broad meta-analysis, you will have more studies to look for. If you do it too narrow, you will have difficulties finding studies that actually talk about it.
Yes, that's true. So let's see.
I have a question, but on the other hand, how do you, when you have a very, like this example that has a that has composite outcomes, it must be difficult to organize your search because it's broad.
Yes,
How do you
that's
do
what I'm
that?
saying. It takes a lot of time and effort, but yeah, that you have to do it because that's your topic, and you might end up with studies which are heterogeneous, right? So that can be an issue. But you need to look at, we'll come to that now, how to do the search also. But as I said, that the broad have more external validity, but they're very time consuming, and you have extensive literature search. So they might be heterogeneous, and ultimately you may not be able to interpret them. So if you're lucky, you'll get something which you can, pull together as a meta-analysis. In narrow are easy, but again, they're less generalizable, and the resources, sometimes you may not be able to find studies, so it may be the other way around. So both have their pros and cons, but basically it depends on your topic, and you have to find the right balance. There's no recipe to it. You have to find the right balance. Yeah. Yeah. So what about searching literature? Can anyone tell about literature search?
So you can do an online. I'm sorry, this is Edith again. So
Yeah,
you can start by making or pulling studies from internet based, like for example ProMed or Cochrane, or you can also go through the gray literature, which is the one that is not published yet, or which wasn't not published.
Yeah.
But sorry, just to add, but I think we have to have.
On 1 second.
Hello? Sorry. Can you, hello? Anyone talk now?
Yes, Keiko. Mona, leave for a second.
Okay.
Yeah,
Sorry.
now it's here.
Oh,
yeah.
You coming back?
Yes.
Okay.
Yes, I just want to turn my charger off. Yeah.
Okay, maybe anyone can answer to Simone's question, and everyone turn off your mic while you are not talking. Okay. Okay, any volunteer? No one?
I can answer, Keiko. Is it the question was about how do you search in the literature?
Yes.
Yes. Complementing what my colleague said, because I think she already answered, but just to say that we have to use at least 2 search engines, like let's say PubMed and Medline, to avoid bias, to make sure we avoid publication bias. We should search through many engines, and like she mentioned, also the gray literature and where you find unpublished studies. All this to avoid publication bias. I think that's it.
Right answer.
Yeah. So great. So basically,
sometimes I forgot to say one more thing, that you should also avoid language bias. So besides searching only in English, let's say if you're doing a study, like in my case it would be in Brazil, I would try to use also a search engine and studies like Cielo.
Yes. So your language specific database also you should search. Sometimes you may even need to contact the authors. You may have seen a conference abstract and you think you can put it into your meta-analysis. You might need to contact the authors and to give you more details about it. Sometimes you even need to go to clinicaltrials.gov to see what all trials have been registered, what have been done, and whether they've been published or not. And you can ask the authors for that unpublished data if you feel it's important to your meta-analysis. So the searching part, I mean, it takes really hard work, and especially if your question is broad, it will take really long to collect these studies, go through it, and read them and extract the data from them. It's really hard work. So but then what is the disadvantage of gray literature? I mean, you have worked hard to collect it for your meta-analysis, but what can happen when you include it in your meta-analysis?
Can I answer the question? I'm sorry. I'm Fatima. Well, there are many disadvantages when we use literature or studies with a poor quality, because our other results, when we get the pool effect, gonna be biased because of that kind of trials that we are considering in our meta-analysis. That's why I do not agree with considering a broad searching, because we need to be picky and try to pick out studies with high quality, with good methodology. Because if the studies do not have a specified methodology, it's going to be hard. It's going to be hard to do the analysis.
Yeah, so they're not published, and they are not peer reviewed. So that's another issue.
Sometimes there are studies that they do not specify the type of randomization. They do not specify the blinding. So that's why we need to assess the quality of the studies. Yes. We need to consider.
So they can introduce more heterogeneity, and since they are low quality studies, they can bias the results. So if you're including them, you need to be careful about them. Maybe you can do a subgroup analysis later on with them, like
sensitivity analysis, maybe.
Yeah, sensitivity analysis or a subgroup analysis. One subgroup with the good quality studies and one subgroup with this, and see how it goes, right?
Yeah.
Okay. So
sorry, can I do a question? Can I do a question regarding the previous slide? How does the Cochrane control clinical trials register works?
This is the clinical trials, not the Cochrane, the clinicaltrials.gov. I was talking about Cochrane conducts.
Yeah, Cochrane control clinical trials register. Like, how does that data works, or that register?
I can go to the website and say you want me to do that.
But is like a register? How can you like accede to publish your? How can you get like a clinical trial to be published?
Registered. Any trials which have been before you do a trial, you have to register it somewhere.
Mm-hmm. So, it's just like a register, a type of register for all the clinical
you can find you can find the trial on your subject there and see then whether it's been published or not. It is just to search an additional area to search. For example, it may be still ongoing and they're writing up the paper and it's not been published. So that's why you even go to the clinicaltrials.gov.
Great, thank you.
Yeah, so this is regarding the study selection. It's just anyone wants to go through it and comment on it? Should I ask, or anyone wants to volunteer?
This is Ida again.
Please, yeah.
A single reviewer examined abstracts retrieved by the electronic search to determine which articles warrant full text review. So technically, ideally, two people should review studies to be included in the meta-analysis, right? Because if somebody, just one person does it, then that person might be omitting some useful studies that we could include in our meta-analysis. So the best scenario would always be to have two or more people selecting studies. Also because they can disagree in the inclusion and exclusion criteria.
Yes, that's correct. So one person alone, there is a risk of bias and missing out studies, and that's why at least two or more reviewers should be there. And if those two, suppose two are there, those two are disagreeing on something, the third one can give the final opinion even during data extraction or when you're grading the studies for their qualities. So they also included studies with a longitudinal design. You want to comment on the last few lines also? Was there something positive also in this paragraph? Any positive thing?
I think the positive thing, well, I don't know if it's truly positive, but they did not apply a language restriction. So this avoids language bias because you're including different languages, but maybe at the end you're going to have a big amount of studies to consider. But you avoid the language bias.
Yes, but you may get good studies if you don't apply a language restriction. It's not that because once you search those studies, you're anyway going to analyze them for their quality, right? It's not that you're going to include it anyway. Okay, so we did this. Yeah, so as I said earlier, you can analyze the studies and score them. Anybody is aware of the score, Jadat scale? Can you hear me? Yeah, so here they say two authors completed the assessments and there were no differing views, and this is the Jadat scale criteria. Do you think it's a good thing to use a scale? Can you hear me? Can you hear me?
Yes, we can hear you.
Okay, I thought nobody could hear me. Okay, so yes, please, yes or no, it's a good idea to use a scale, or we can just read the study and say, no, I don't like it, it's not good.
I think it's a good idea to use a scale because you get like a value that you can compare between one study and another and determine if a study is better than the other one.
Yeah, right. So it gives you a very objective grading. Otherwise, it can be very subjective and vary. But at the same time, it can have some issues because some items which may be important in some situations may not be relevant in the others. And in these scales, they may get the same weight because in case of mortality, blinding may not be that important, but in case of, whereas in some other case, like I'm checking the pressure, that case blinding should be more important. So that's why the Cochrane collaboration has come up with the different scale, which does not include, they have the Cochrane bias risk assessor, and it does not have a score by numbers. It just gives the author's judgment. So, and then it gives the overall risk, like low risk of bias, some concerns, or high risk of bias. So both are ways to grade. And this is an example where if you see in the quality assessment, both the Pedro scale has been used. It's quite common in physical research and neuropsychiatric research. And Also, they have used the Cochrane risk of bias tool. So both have been used, right? So to assess the bias. Okay, so once you have selected the studies, then you need to make your table 1. In your RCT, when you make your table 1, it contains the baseline characteristics of your participants, right? Same here, the participants are studies. So here also you will include the baseline characteristics. So like here we have the various on top, we have the name of the studies, and then on the column left side, we have the details like what was the study design, and this is the registry we were talking about, the start date, the end date, the main inclusion criteria, and like depression cutoff level. So all the variables which you want to look at, you should decide, just like you make your Excel. So you should you should choose those variables beforehand, and then when you're reading the studies, you should keep on adding them to the table so that your analysis becomes easy. And then you have the flow chart. Can anyone explain this flow chart? Should I call somebody?
Can I?
Maybe
This flow diagram is I think it's proposed by the Prisma
Yes.
statement, and following which we can first pull all the searched articles in the first box, and then exclude those ones with each exclusion criteria followed by another step by step, so that it finally reached to the final studies eligible for inclusion. And those excluded study will be listed on the right side and with the reason and the number.
Yes. Yes. Yeah, that's very important, and everything should be documented, that why did you exclude that study and why have you chosen the ones which you have chosen. And if you can see here, they started out with about almost 3,000 articles in the beginning, and then they found that about 1841 were not relevant, and from 27 they came down to ultimately 9 studies were included. So it's a lot of hard work. So once you have got your studies and you've extracted the data from them, rest is fairly simpler. So once you have all your studies here, can we just pull the data from the studies? So what was the primary outcome in the study? The score?
You have
Can we
to,
just combine?
at the end, you have to find an effect size to summarize, like, because different studies use different scales. So you cannot like combine those data. You have to find an effect estimate to combine it and pull it together.
Yes, very good. That's excellent. So we need to know 4 key concepts before we combine the studies. First is the effect size. Then we have to add a weight to the effect size depending on what model we choose to combine. That further depends on the heterogeneity. And also we need to know about the publication bias, right? So effect size is so the magnitude and the direction of treatment effect for each study. And we basically kind of transform it into standardized measures which are unitless. So we get the precision, and we also need the confidence intervals. So both can be calculated, right? Sometimes it's very rare that all the studies have the same scale and the same outcome measure. Then that's the only situation where you don't need to calculate it. So these are the various effect sizes which you have. So for example, if your outcome is categorical, you can have an odds ratio, risk ratio. If it's continuous, you can have a mean difference or a standardized mean difference, which is more common. You can have a correlation coefficient. And in case of time to end data, you can have a hazard ratio. Now, when you look at the papers, every study will not report an odds ratio or a risk ratio. And if you've decided that, okay, your outcome is categorical and you want to report a risk ratio, then you have to kind of convert the data which you extract from those papers into a risk ratio. And let's have an example of that. So for example, here the authors wanted to report a risk ratio of wound infections after surgery compared among two groups. One group was general surgeons, the other group was pediatrics surgeons. So so in the paper by Collins et al., which they had selected as one of the papers for their meta-analysis, so they wanted, they found that in the DGH group, the general surgeon group, 15 out of 196 had wound infection post-surgery. So here you can see 19 is the number of events, and now 196 is the total number of participants in the general surgeon group. Whereas in the pediatric surgeon group, 4 patients developed wound infection out of a total of 206. So this data is what you need to extract. Now from another paper, they have written that 11 had post-op wound infection, and but 11 out of how many? For that you had to go to the table which is given down in one of the tables where you found how much was the total number of participants. And then they wrote that no post-operative complication was noted in the pediatric surgeon group. No means 0, right? So they have 0, and again for the total you have to go to the table in the results section, which is 264. So that's how you get your numbers for the data analysis. So then once you get the effect size, you can't combine it, right? You have to add weights to it. So why do we assign weights?
We assign weights to, oh, sorry, someone was going to.
No, go ahead.
We assign weights to the studies to know which study is more significant or has more part in our whole meta-analysis, or to know which one is more responsible of the whole meta-analysis we're creating.
Okay, so yeah, by the weight we know which is more responsible, but we add the weight depending upon what? Like weight is important, right? In simple terms. So which studies do you think are more important?
Size. Larger size carry more weight.
Why do larger size carry more weight? I mean, it's not literally like, yeah, larger size carries more weight, but why?
Because the sample size make the study get more power.
Why?
I'm not sure.
You're in the right direction.
It's the variance, yes? Yeah.
Yes. So
in the variance, yeah.
Variance. So the larger
confidence interval
are small, right?
Yes.
So that's why they have more weight, right?
Yes.
So weights are on the basis of the sample size, isn't it? Because the one with the larger sample size will have the less variance, less smaller confidence intervals, and you'll try to believe it more. So that's why you want to give it more importance, isn't it? So that's why statistically you're giving a weight to it, you're multiplying it by a larger number, right? Understood?
Yes.
Okay. That was in very simple terms, just to get the concept of it. So why do we give weights? First of all, effect size of each study is imprecise because each study will have a different sample size. Like we saw in the example I showed you, one study had 196 in one group, whereas the other had 200 something patients. So different studies will obviously have different number of participants, and you want to combine them all. So weighting is then done on the basis of the sample size of the variance. It gives better precision also, and higher quality studies, which are a stronger evidence, get more emphasis, right? So this is how we calculate. It's don't get scared with the formula. It's very simple. It's 1 over the variance, right? That's it. So weight is 1 over the variance, which you multiply it with the effect size, and then you add it up, and then you divide it by the sum of weights, right? So it's actually very simple. And then you can even calculate the confidence intervals. So it's called the inverse variance method. Okay, so what is heterogeneity?
Hi, can I make a question, Mona?
Yeah, sure.
Yeah. For example, if we have two measures of outcome, let's say one outcome is categorical and the other is continuous, and those two papers are important, can they be included even they have different unities, different variables? Should
Okay,
we
so
transform?
you have to transform them. That's what I was trying to say. You have to transform those variables into the same ones. So for example, you have the risk ratio we were calculating. So you need the numbers for that number who developed the condition divided by the total number, right? So one study, they would have reported a mean outcome, maybe a mean of something, right? So you can't fit it into a risk ratio, right?
Okay.
But then you can read up the paper and find out what was the total number of participants. And since your data is binary, unlikely to be mean, but somewhere they would have reported that, okay, so many patients developed wound infection. They might have subgroups where they would, so you might need to add those subgroups into a total, that how many patients developed the infection. And then you have to like read, or sometimes you may even have to call up the authors and ask them. There are ways you can convert. You can convert based on the t value, the p value, the beta coefficient. There are like, if you go read the books or go on the internet, you will find that there are ways where you can convert the F statistic, the T statistic, and you can get convert them to a R value. You can interconvert and get a rough estimate of what you want. It is possible.
Okay, thank you.
But then ultimately, whatever you're extracting from the study, it has to be same and standardized. Only then you will give the weight. Okay. So what is heterogeneity? Anyone wants to answer?
Anyone from China? Cool. Or maybe
when the results are different. I'm sorry, Fatima.
Okay. Fatima.
When we have different kind of results, I mean, you have a trial that says that this intervention works, and the other trial says the opposite. That intervention does not work.
Mm-hmm.
So we have different kind of results.
Is that heterogeneity? That is extreme heterogeneity, 100% heterogeneity. Okay.
But it's more like the variability we have in the studies.
Yes.
And as we said, variability related to the size, right?
Variability will?
Related to the sample size of those studies?
Of each study, yes. Correct,
yes.
Correct. Yes. So how will you look for it, heterogeneity? One you said was based on the sample size, but how will you...
We can also look at the confidence intervals and see if they're too small or they're too big.
Yes. And how can you compare, like what you're looking for is a difference between the studies. Like now, for example, in that previous paper, ultimately they selected 9 studies, isn't it? When we saw the Prisma flowchart. So we have to see those 9 studies. Are they heterogeneous or not, right? So you're comparing these 2 studies among themselves. Are they same? Like, are they all apples? Or are they some green apples and some red apples? Or are they apples and oranges, right? So you have to see those 9 studies.
Can I ask something?
Among themselves. Yes, please.
It's Flavia, my name. It's only about sample size, or it's also about effect size? Because some diseases have like it's not very... So
It's a little related, but effect size is basically how big is the effect. Like 0.8 would be a good effect size, whereas a small effect size would be smaller,
Yeah,
like
different effect size. So if the study have a different effect
indirectly,
size.
yeah. So you have to look at that plus the confidence intervals also, right? So let's see how we look at that. Yeah. So the heterogeneity can be clinical. It can be due to the methodology or statistical, right? So you can inspect the forest plot, and when you're inspecting the forest plot, you can look at both the effect size as well as the confidence interval. Then you can do some statistical tests, and you can do a sensitivity analysis. You can do meta-regression and subgroup analysis, right? So what about this forest plot? Are they heterogeneous or homogeneous?
Heterogeneous?
Why?
I believe that because there isn't a unified result. It's very broad about the confidence intervals and these things.
Yes, great. So some studies have the confidence intervals are not overlapping among the studies. And if you see the line of no effect, some studies have effect sizes on the left side, some have on the right side, isn't it? You can see the line of no effect. I don't know if you can see that. This is the line of no effect. So some studies have effect sizes here, some have here. And these confidence intervals are very wide. They're not overlapping at all, right? So all these studies are heterogeneous. What about the statistical tests? Can anyone tell me regarding the two tests? You're familiar with these two tests?
So one of the tests is the Cochrane's Q test. That's Datados. And the other one is an I square, I think.
Which is better? Which is better?
Well, I think the I square allows you to say how heterogeneous, how much it is, but the Cochrane gives you a specific value, so I would go for the Cochrane.
Oh, okay. So basically the Cochrane tells you, what is the null hypothesis is that the observed difference across studies is likely to be merely due to chance. So if you don't get a p-value less than 0.05, that means the studies are homogeneous, right? It just tells you whether there is heterogeneity or there is not. Okay. And it has a low power to detect heterogeneity. Means if you have less studies in your meta-analysis, you may actually have heterogeneity, but the test will give you a p-value of say 0.3, and you think that there is no heterogeneity, right? So that, whereas the I-square test will tell you the degree of percentage of heterogeneity, which is percentage of variation, which is due to the heterogeneity, rather than whether it's there or not. So I-square gives you a better information, right? So once we know that there is heterogeneity, what to do out of all this? Which is a good thing to do? When do you
Sensitivity.
do not combine study? Huh? Sensitivity analysis. Okay. So you can do either any of these. You know, if the results are too different, then it's not a good idea to combine it. And why is that? Because there are, suppose, 10 studies, 5 have a very high positive effect size, 5 have a very high negative effect size. When you combine it, it will lead to a no effect size or a very small effect size, which is misleading, right? So it's better not to combine them at all. Or if there is some heterogeneity, you can combine it with a random effects model. You can also do a subgroup analysis, like the 5 with the high, with the positive results, you can combine them separately. And the one with the negative results, you can combine them separately. You can do a regression to do why it's happening. You can also do a sensitivity analysis. So depending on your data, you can do any of these, right? So again, before we still haven't combined all our data, we need to decide which model do we want to use. So what is a fixed and what is a random effects model? Anybody wants to tell?
The fixed effects model assumes that the intervention over the comparison is giving a fixed influence to the population across all of the included studies. Otherwise, a random effects model is adding a random residual to the formula to allow each study to have to allow the intervention has different size of influence across each study.
Yeah, so in a fixed effect model, there is just one true effect size. That's what the assumption is for every study, and any variation is due to chance. So you can use the inverse variance model to give the weights. There is no between study variation. There's only within the study variation. There's no between study variation. So whereas in case of a random effects model, you have something which is called as a between study variance also, just like you may have studied in ANOVA. So here, so what happens is here, when you're taking the weights, when you have the inverse variance, that is 1 over the variance, you add another factor called tau square, which is accounting for the between study variance. So when you're dividing it 1 by a larger number, so your weights will be more balanced and your larger studies will not dominate the analysis that much, and the smaller studies will not become even more small because they have a less weight. It kind of balances out things. Did you get the concept? So I'll just show you the okay, so here you have the weight is 1 divided by the within study variance, and you can see here the size of the square is the weight. So the larger study has the biggest square and the small studies have tiny squares, and the confidence intervals of the diamond, they are narrow. And whereas in the random effects model, the weight is 1 divided by within study variance plus between study variance. So you can see because of the increased variance, the confidence interval is bigger. The diamond is more broader, right? And the study, which is the second last, you can see had a tiny square that is less weight, now has a more weight. Whereas the one which had a higher weight is kind of balanced out, right? So this is what the random effect model is doing. So another thing which can be done is a subgroup analysis. Do you want to take a minute to read it and answer the statements? Yeah, can you read the first question? Let's do this together. It can be inferred that homogeneity existed between the sample estimates across the trial. Do you think that is possible?
No.
Do you think it's homogeneous? All no. Okay. Then the other question is, homogeneity existed between the sample estimates in the subgroups of ward and team. So if you look at each subgroup separately, the ward and the team, do you think they're homogeneous among themselves?
Yes.
Are you sure? Look at the team.
They have opposite results.
Yeah, they have opposite. But among the team group, are they homogeneous? And what about the ward group? Are they homogeneous among themselves? Which
Yeah.
one is homogeneous?
Well, the wards is a little bit better, but none of them are homogeneous.
Yeah, so there is some amount of heterogeneity, but they can't be called homogeneous, especially the ward one, because the confidence intervals are really wide and the effect sizes are not close together. If you see the dots or the squares, they're not very close towards the central, towards each other. The line of, they're not very close towards each other. It can be inferred that the effect of treatment on the primary outcome was different in the subgroups of wards and team on the basis of statistical significance in the subgroups. What do you think about that? On the basis of statistical significance in the subgroups. So what is the significance, statistical significance in the ward subgroup of the overall effect? Where is the overall effect here? This is a test for overall effect, isn't it?
The alpha is 0.001. That's it.
Yeah.
I can't really read. I'm over 40.
Yeah, it's very small.
So,
yeah, it's correct. So it is significant, right?
Yes.
What about the alpha for this one, teams?
It's 0.006. But if you do subgroup reanalysis and you can't really use such a low alpha, because when you divide it by subgroups, the chance of being wrong is very high.
Yes, that's a very good point. So what do you do then? If you do multiple analysis, what do you need to do?
Bonferroni.
Bonferroni. But then even then, would you still look at this or would you look at some other test? Because here what they've done is they're comparing the ward among themselves and the team among themselves, and one is coming significant, the other is coming not significant, which may be because the number is so small, they may have less power, right? It's just for studies. So which other test do you look for when you're comparing subgroups? It's given right at the bottom.
It's saying test for subgroup differences, but I don't know what it is. I have to
What
be
is the
honest. I
test?
never heard about it. No, I have no clue.
Okay. You have done, anybody else would like to help? What test are we talking about when you are comparing subgroups? Okay, read the last. A significant interaction existed between the subgroups of ward and team in the primary outcome. So what is interaction here? Have you, is anybody aware of the test for interaction?
We actually didn't study that. It was not in the Well, I didn't actually. I'm sorry.
Okay, I think it's in the assignment, but okay, we'll come to it. Don't worry. Okay. So the test for subgroup analysis is the test for interaction. So here it's significant, and it's 0.003 here. And this is the test you want to look for. You don't want to look at the p-values of the separate subgroups, because these are likely, this is just comparison in between them. The p-values are not comparing one subgroup to the other. They're comparing within subgroup populations. So that is a concept which you should take home from the subgroup analysis, that it's the test of interaction you should look for, and not the p-values for each subgroup separately. I have more examples later, so maybe we can go on to that. So, and this is the meta regression, which you can do again to look for any heterogeneity or any factor which is influencing your effect size. Here the effect size is the odds ratio, and it's a publication year and you think that is a publication year which is influencing the study, that the effect size keeps on changing with each publication year. You see that, and each study is represented with a bubble here. The largest studies have a larger bubble, and it also has the confidence intervals. You can get that, and anything outside of it, if you have a larger bubble outside it, then basically that study needs to be excluded. And here you can see that since there's a slope of the regression line with each publication year, the log odds ratio is decreasing. So there is some effect modification here. So what about publication bias? What is publication bias? I think we talked about it earlier a little bit. So how do we detect it, and why does it occur?
Can I answer?
Sure.
Publication bias would be when we are more prone to publish the results that are more positive, and we usually try to hide or discard all those drafts that don't show those positive results.
Right. So what does it lead to ultimately? What is the effect of all this?
That most of the literature that we're going to find is going to be biased, because it's going to be more prone to show positive correlation instead of the negative correlation, or the null correlation.
Yes, excellent. So if you have, for example, there was one example where they saw on a particular topic, they did a meta-analysis and saw the effect size, and then they took all the unpublished studies which were with the FDA, and when they added it, they saw that the effect size had decreased when we added those unpublished studies. So it may give an overestimation of the effect size if there is publication bias. So how do you detect it? What is the test, in other words, for
funnel plot.
looking for publication bias? Yeah, Paulo? Yeah.
Funnel plot. The funnel plot.
Funnel plot, yes. What is a funnel plot?
It's like a graph where you can see if there is or not publication bias. Yeah, that's the
Okay,
graph.
tell me then. Is there publication bias here?
For me, yes.
Yes, why?
Because mainly in, I believe, the small studies, there are more in a positive effect than a negative. There is not symmetry between them.
Yes, so it's asymmetrical, right? And below you can see some studies are missing. Which studies are in the lower part of the funnel? Which type of studies will be there in the lower part of the funnel?
The small one, the small studies.
Small. So if it was a random sample, then the small studies will be there, obviously. So both type of studies should be there, one with a positive effect, one with a negative or a less favorable effect. But if the ones with the less favorable effect are missing, then there's a chance of a publication bias. So basically a funnel plot is nothing but a scatter plot. So you can see the studies are plotted. Below is the effect size, and the y-axis is the variance, right? So and if you see here, the variance is decreasing as you go up. It's not, zero is not at the, at the intersection of the x and y axis. The zero is up. So the studies with the less variance are on top. That means the ones with the larger sample size or the less variance will be in the near the apex of the funnel, right? What are these central line and the sloping lines? What do they signify? What is the central vertical line?
Standard error.
The central one.
Sorry, could you repeat the question?
Is this line? What is this line?
Oh, the neutral effect. No, neutral effect.
Neutral. No.
Is the overall effect?
Yeah, it's the overall effect.
The pooled effect.
Yeah, the pooled or overall effect.
Yeah, pooled effect. And the other, they're called the pseudo confidence intervals. They just tell the spread. They're not exactly confidence intervals, but they're called pseudo confidence intervals, 95%, and they give a kind of a estimate of the spread. Okay.
Sorry, could you explain that? I thought on one side would be the positive effects and the other the negative studies.
Yeah.
So I couldn't understand the middle. What does it mean? Could you explain again?
So here on the, it's the same diagram. I've labeled it here. So on the x-axis is the effect, what you're measuring. Here you're measuring the odds ratio for each study, right? And on the y-axis is the precision or the standard error, right? So if you see at the vertical line will represent the total estimate of the treatment effect, the pooled effect size, right? Now these tiny squares are the studies. So if we draw a random sample, then you will have both small studies and large studies. So you'll have large studies who have a precision will be more. If precision is more, they'll be near the top of the funnel because that's the y-axis and 0 is on top here. So studies with more precision will come here, isn't it? Smaller studies will obviously have less precision, so they will come somewhere here. And it should be both sides, just like here both sides are there, with the larger effect and a smaller effect. And here you only have studies with a larger effect. The ones with a smaller studies with a smaller or reverse effect are missing here. Am I clear? And these are the pseudo confidence intervals, which just tells you the spread of the variance overall, 95% confidence intervals. Did I answer your question?
Sorry, I'm not
Did I
sure.
answer your question? Yeah. Okay. You were asking about this area, right? The lack of smaller studies. This is what you were asking?
For me, Renata, no, for me at the area, I understood the lack of smaller studies perfectly explained. What I didn't understand well was this middle line, this vertical line that.
This is the effect size. What you see in the diamond in the forest plot, the center, the apex of the diamond, that value.
Okay, the
we
middle
just see in the
value.
forest plot.
Okay, thank you. Thank you.
Weighted pooled effect size. You will see in any forest plot. Yeah. Okay. So one thing I want to just highlight that before doing a funnel plot, you should rule out heterogeneity, because if heterogeneity is present and you do a funnel plot, then the asymmetry may come due to heterogeneity and not due to publication bias, because an asymmetric plot may be due to other reasons also. So you should first rule out any heterogeneity, and then go in and make a funnel plot, right? Okay, this is, so once you have a funnel plot, you know this publication bias, what to do about it? Like you can't, I mean, one is of course you can look for those studies, but if they're still not there, you can do an adjustment, which is called a trim and fill. If you see here again, like in the previous one, you can see in the lower side that empty area where the studies are missing. Now, if you do this analysis, it kind of removes, first is the trim. The trim will remove some studies which are a little extreme, and then it'll fill a similar amount of studies, it'll impute them, put in some, false studies, and then make the estimation of the total effect. What's vertical line you were asking me? And that is the adjusted effect after correcting for the bias, after correcting for the publication bias. So if you see here, the vertical line has shifted in each of the panel plots. So if that is the pooled effect size, and that is the adjusted pooled effect size. It is more towards 0 in the adjusted one, the one in the pink arrow, and the white circles are the studies which were missing, which have been imputed by the software, and then a new effect size has been calculated, which is more conservative. Did you understand this concept? And
Yes.
this has become quite popular like recently, and you can see how the more and more studies are doing this trim and fill analysis for bias adjustment. So now we can finally move to stata. So I'll just show you these are the basic skeleton of commands which you might need, and how your data is, your command depends on that. So either you have numbers, like I showed you, you have the number of participants, or you have the mean and the standard deviation, then you need a different command to start with. And if you already have calculated the effect sizes, then you need a different command. So like in survival analysis, you have to tell stata that, okay, this is my data set and I'm doing a meta-analysis. You have to declare your set as a data as a meta-analysis data. So for that, you have the command here, meta set ESSE is when you already computed the effect sizes. So ES is the effect size, which you can, and SE is the standard error. And if you don't have a standard error, you have confidence intervals lower and upper. Your command is meta set ES confidence interval lower and confidence interval upper. On the other side, if you have just numbers, like we saw in that paper from which we extracted the numbers, your command is meta E size. And if you have categorical data, it is, you go by your 2x2 table. So we just do it in stata, but this is just to give you an overview. And then the commands are fairly simple. These are the basic commands. Now you can add on to these commands like subgroup, if, by, like that. So we'll do that. So what command will you use for this data? What type of data is it? To declare it as a meta-analysis set to stata. These are the commands. For this, what type of data is it? Continuous or categorical?
Continuous?
Continuous. Yeah, the numbers are continuous, but it is event 1 and event 0. So what type of outcome is it? Like, what test will you do for it? Will it be a mean and a standard deviation, or will it be a proportion?
A proportion.
If you have number, yeah, it'll be a proportion, right? So for that, you will use this command, meta size n11, n12, and this command is to be used. We'll just do it. So this is how you should enter your data in your Excel and then stata. So if you have number of events, like we had in the previous one, so you basically, what you need is the events and no events. You can have the total number. If usually you have the total, you can subtract it. So you get these columns, that number of events which have happened and number of patients in which the events have not happened in the control group and the treatment group. So you have 4 columns. You need at least these 4 columns. For continuous variables, where you don't have the effect size, you just have the data, you need the mean of the and the standard deviation of each, the treatment and the control, and the number of patients in each group, right? So this is how you need your data to be entered in Stata and your Excel also, right, initially. So Stata has this graphic user interface which makes life easier. You don't have to remember the commands. So we'll go through it. But before that, just we'll just read this forest plot here, and then we'll go and make our forest plot. So anyone wants to comment on the zones here? Zone 1, zone 2, what are these? I've just made it to zone so that like it has a lot of information in the printout, so nothing is missed. So what does zone 1 tell us?
This tells you the studies that you are analyzing in the meta-analysis, and you can see the proportions we were talking about the events for each of the studies.
Yes. And what about the zone 2?
Zone 2 is giving us the effect estimate for each of the studies with their included confidence interval.
Yeah. What is the effect estimate here? That's important. It's written there, the effect estimate.
What is the what? Sorry.
The effect
Risk
estimate.
ratio.
Like
Risk
yeah,
ratio.
very good. Yeah, very good.
1.79.
Yes, that is the total one. That comes in zone 4. So zone 2 will give us for each study. First of all, it also tells us what we are measuring here. We are measuring the risk ratio, and how we are measuring it. The model is also shown there. It has a random effects model by the. So it's measuring the. It's not a fixed effects model. It's a random effects model, and it also gives us the confidence intervals of each study and the
weight.
The weight.
The weight. Very good. So what about zone 3, the forest plot? What are the squares and the diamond and the lines? Already we have discussed it. So
so in
what is
zone 3, we are seeing what zone 2 is telling us, but visually. So we have the weights, which are represented by the squares, and the diamond is the overall pooled effect, the overall mean.
Yeah. So overall pooled effect. So what about the size of the squares? Is it important?
A bigger square means it has more weight, meaning it has more sample size.
Yes.
Variance.
What about the horizontal line?
Those are the confidence interval.
Yeah, and the bigger the line, the longer the line, the
longer the
bigger
confidence interval.
Yeah. Okay. Is it what is the vertical line?
The pooled F.
No. What is written below the vertical line here?
Risk ratio is the same for both groups.
No. This is a line of no effect, because if you have a risk ratio of 1, this is a ratio, 1 means no effect. So always in the first plot, I mean, it's your choice if you want to plot it. You have a line of no effect and you have a line of the pooled effect. Both lines can be there, or you cannot put them there also. Here, it's 1 in case of a ratio would always mean the line of no effect, because it's a ratio, and a ratio of 1 means no effect, right? If it's a difference, then it would have been 0 there. If it's a mean difference, standardized mean difference. So if the confidence interval is crossing 1, what does that mean?
That is not
If the
significant.
horizontal line is touching. Yeah, because it's crossing 1. So in how many studies you feel are significant here?
4.
Okay. Yeah, and what about the diamond?
Sorry, Mona. Can you repeat that the last part, because I don't understand when the horizontal line cross the no effect line means that is not significant.
Yes, because just like your confidence intervals for your when you do your t-test or any other statistical test, if your confidence intervals in case of a ratio, for example, you're doing a regression and your confidence intervals for the ratio include 1. 1 means in a ratio that there is your risk ratios, you're comparing general surgeons to pediatric surgeons. So if the ratio is 1, that means there is no difference, right? So 1/1, so if you subtract the 2 also, it's 0, right? So, so this is a line of no effect. Many forest plots have this line of no effect. If your outcome instead of a risk ratio was a mean difference, then the line of no effect would be 0, because and any confidence interval which passes through 0 would mean that actually, you know, that is what a confidence interval is. When you're drawing samples, you're doing, you know, you have the limits, upper limit and the lower limit, and your value can lie between the two limits. If that limit includes 0, that means it can actually be 0 anytime, right? So there is a chance that usually your results will not be significant. Are you getting the concept? So whenever the confidence line crosses the line of no effect, means there is no effect. The studies, there's no difference between the general surgeons and the pediatric surgeons in this case.
So can I ask a question?
Yes.
So if we decide, because this data does not plot the line, if we decide that we do not plot the line, it will always be a rule that for a risk ratio, the line should be in 1, and for if we're having a continuous variable, we're having the line in 0, right?
Yes, yes.
Okay.
Yes. You cannot change this line. Yes. Yeah, that's the right concept. Yes. So, what about the diamond? Does the size of the diamond matter? Like the area of the diamond, just like the squares, does it matter? You have a bigger diamond. So basically, it's the horizontal ends, 2 ends of the diamond which matter. The overall size, I mean, this size vertical does not matter. This point on the axis tells you where the pooled effect is. Some first plots will have a line drawn through here, which will tell you that this is the pooled effect, which is nothing but the pooled effect, which is showing up here, 1.79. So at 1.79, there might be a line here also. So, and these ends will tell the confidence intervals. Other than that, so the horizontal spread of the diamond is important. It tells you the confidence intervals. And if the diamond also crosses this line, that means there is no difference. So significant difference even in the pooled analysis, right? So what about zone 4? Oh, sorry. So zone 4, as we already discussed, has the pooled risk ratio for all the studies along with the confidence intervals, right? What about this zone 5? We already discussed these tests. So anyone wants to comment? You have the I-square there and the chi-square there.
So these are our 2 tests that we can use to assess if there was heterogeneity in our studies, between our studies or not.
Yeah, so was there heterogeneity here? And how much was it? How much is I-square?
90%.
Yeah, what does that mean?
A high?
Yeah, that means 90% of the variability is due to heterogeneity, which is pretty high. And you can see that in your forest plot visually, isn't it? See how far away the squares are from each other, right? Okay. So then this is another study, not the same study. What is this graph showing? This is not a forest plot. What plot is this?
This is a sensitivity analysis.
Yes, excellent. And what does it, how do we interpret it?
Here we can see the effect estimate that we would obtain in each case if we removed each of the articles of the studies.
So how do we interpret this one? Which studies are more, you know, you would like to point out which studies here?
So I'm not sure if you have to take a look at the ones that are in the opposite side of the...
Yeah, which ones are those?
Like, for example, Mizuno.
Okay.
I don't know if that's how we do.
Okay, so basically when you remove the first study, your effect estimate is 1.18. And when you remove Mizuno, your effect estimate shifts to the left. When you remove the third one, it is little towards the right. When you remove Song, it goes way towards the right. So when you remove Mashida, it's again close to 1.18. When you remove Bay, it moves to the other side. These are the two studies, and maybe the third one also, but especially Song and Bay are the ones which, when you remove the effect size, is shifting more towards the 1.4, you can say. From 1.8, it's going to the other direction. So these are the studies which you might want to say that, you know, have an influence on your analysis. You might want to remove them because they are having the maximum effect, isn't it?
But do you have to remove it? That's my question. I mean, if this study says something, how can you remove it from your analysis?
You can't remove it, but then I'll show you what they reported, the authors here reported. So this is how they reported it, that sensitivity analysis was employed by omitting each study. So the p-value changed from more than 0.05 to less than 0.05 when they omitted these two studies. And the result indicated that the pooled odds ratio was sensitive to these studies. So that's how you report it. You report the entire analysis also, and you report your sensitivity analysis also, because these studies did have an effect, right? So this is how the authors here reported it. They did the analysis and then that's how they reported it. I mean, this is only for the analysis.
Just to make sure. So they did include the study, or they didn't? They did include, but they said that if they would omit this study, the p-value would change.
Yes. So they basically presented both the results with the study and also without these two, right? And saying that these studies, caused the effect to change.
So, Mona, can I ask something?
Yeah, sure.
So the sensitive analysis would be important when we don't have an effect. How can I say that? That is very strongly statistically significant. Because if we have a big diamond saying that is significant, and what should the sensitive analysis be important for?
Usually you do it to look for heterogeneity, and when you have heterogeneity, what you're saying is a result of heterogeneity, that you will not get a very good effect size, because if you see some studies are in one direction and the other, when you pull them up, you will get a smaller effect size, isn't it? That's what is heterogeneity. So you're exploring heterogeneity. And so when you see your forest plot and you see there's not much overlap and then there's heterogeneity, you want to know what is the reason, which studies are causing the heterogeneity. So now this analysis will tell you, and then of course not even, you may get a effect size also which is significant, But even then, if you have your I-square is high, and you can see in your forest plot that the heterogeneity is there, then you need to see the reason for it. And this gives you that, okay, these two studies are the reason. You might need to go back and look why, in these, what was the different population, was it the methodology was different, and did they measure the outcome differently? So all that you might want to analyze. So one reason is, of course, you're not getting significant result, but the other reason is per se heterogeneity itself.
So the reader should pay attention more specifically to an author and understand if this trial would not be included, the result could be different, right?
Yes. And why? You should look for the reason. Maybe it was done in a very younger population. So all that you can put in your, mention in your discussion in the meta-analysis.
Okay, great. Thank you.
One question before we pass this slide. So when we're seeing the sensitivity analysis, so pretty much we just have to see which study will move our effect size farther away from the pooled one, right?
Yes.
Okay, now I got it.
All this is to, all these tests which we are doing are there to see the reason for heterogeneity. Subgroup analysis, meta-regression, all this will tell you why there is heterogeneity, which study is causing it. Is it a study, and is it a variable like studies done, in the 1970s versus in the 2000? Is it any variable? Is it the age of the participants? Is it the latitude, which country it was done? Even that can be, so meta regression can tell you that. So here you're exploring the reason for heterogeneity. If there's no heterogeneity, you don't need to do any of this. It's only to see the reason for heterogeneity. What is causing heterogeneity, and then you look for it, then why, right? So, and this command I hope you all have installed for the sensitivity analysis and Stata, because it's the only one which needs to be installed. All others are there. So meta inf.
Sorry,
So you can just copy this command. You need to you just need to type this command in Stata to install, because the new Stata does not have the sensitivity analysis included inside it. All the other commands are, everything is there. So you just need to type this in the command window to download the commands for this meta and inf. SSC install, you have to install it. It's not pre-installed. So just type this in the command window and automatically it will get installed the commands. Then we can do the sensitivity analysis.
Mona, sorry, and can I do one more question about that slide?
Yeah.
Yeah, the other one, please, like the sensitivity analysis. Yeah, that one.
Yeah.
So here they take out song and by, right?
One by one.
Yeah, one by one. But why not take out, for example, Mizuno or like the other studies? Because Mizuno, it's like putting the results to the left, right? Like it's deviating the mean to the left, and the other ones are deviating to the right. Like, why do they select those studies and not other ones?
Yeah, first of all, that's a good question, because if you see 0.99 is towards the left, so on the left side they're overestimating. They are like, these are causing overestimation of the effect. If you see towards the right is the higher effect size, 1.18 and 1.40. So they're pulling the I mean, if you remove them, so the they're pulling the effect to the opposite direction actually. All the others except, and they calculated the p-value. So probably for Leo and Leo, see, they're on the opposite side and towards a larger extent. If you see Song is and Bay are more towards 1.4, that is overestimation, isn't it?
Yeah. Ah, so, all right.
So that's, and then they calculated the p-value also and found that these two were the ones which needed to be, which were, causing a bias.
Yeah, I get it now. Thank you.
So once you have done your meta-analysis, you have to summarize the key findings and explain the heterogeneity and studies regarding studies of poor quality and the internal external validity, and what were the limitations of your meta-analysis, what were the plus points, and what are the implications for future research, public health. And when you have done your meta-analysis, you've found further gaps in literature, you can recommend future research that, hey, look, I have not got an answer, both are insignificant, and the pooled effect is not significant among two groups, so you need more RCTs, or you don't need more RCTs. Now we know that this is better than that, so you can make those implications also. So I think we can go to Stata now. So you want to open up your data set. So I'll just open up my Stata. Have you downloaded the data set, everybody? Do you have the data set?
Oh, Mona, I think we can find it in the Google Classroom.
Yeah, I mean, yeah, has everybody? Yeah, please download. You want to take a minute to download it, or do you already have it?
I think you can go ahead, maybe.
I can go ahead? Okay.
Yeah.
1 second. One second.
I can't hear you, Mona. The microphone.
Have you opened your data browser?
Huh?
Can you see my? Can you see this
Yes.
data output here?
Yes.
Okay, so this is the same meta-analysis which we saw earlier, the forest plot. So here you have the general surgeons. Can you see? It's saying sharing is paused. Can you see my screen? Can you see
Yes,
my
Mona.
screen?
Yes,
Yes.
Mona, we can hear you.
Okay, okay. So it shows the GN event is the number of events, and there's a total number of participants in the general surgeon group, and then you have in the pediatric surgeon number of events, wound infection, and total, and then also you can subtract it to get the patients who did not have wound infection in each of the group. So again, you have more, since you know that we can have multiple outcomes in meta-analysis. So this is this is another event. I've called it GN infection. This is PD infection. This is no infection. And so you have different outcomes you can have. Then you can have variables like experience.
Mona,
Can you hear me?
Mona, can you hear me? Sorry for interrupting, but I think that you need to change your screen so we can see the data browser, because we are seeing the main. Yeah, we are seeing the main display.
You're seeing this. Oh, okay.
Yeah. Now we are seeing the results.
Now, oh, okay.
But I don't know if you want to show us the data browser.
I want to show the data browser. Maybe. Okay.
Mona, you wanna show the browser?
Yeah, I'm trying to open it. This bar keeps coming on top of it. Yeah. Yeah.
Okay.
So here we have the study name. Then you have like the general surgeons. I've just named it number of events. This is the total number of participants. So you can just subtract it to get the one with no events. Similarly, for the pediatric surgeons, you can get the event, and then like how many patients had the event, and then total, and then you can subtract it to get how many did not have the event. Then this is another variable. You can look at people who had the infection. So 15 in this group had the infection. Similarly, here in the pediatric group, you can have the ones who had the infection. Then no infection. So event and no event. This is how you enter the data. You can also enter variables like years of experience of the surgeon, year of the trial when it is published, and then you can have the latitude of the country. And then I've just named it subgroup 1 to 3 just for the analysis. And if you already have the log odds ratio with you, you can just put that in also with the confidence intervals. Here I've already done the meta-analysis, so I'll just clear this up. And if you have means and standard deviation also, you can here enter it like mean GN, SDGN, mean PD, SDPD. This is just fictitious data. So this is how you can have your variables for your study, right? So then you have to declare your data to be meta-analysis data. So for that, I'll just go to the window first. So you go here, statistics, meta-analysis, and sorry for my desktop, it's very busy. So you have the so you have the setup. First, you have to set up the data. You have 3 options. You can have 2-group comparison for continuous outcomes, binary outcomes, and or you have generic pre-calculated ones. So here we have binary outcomes. So here you have I have declared this data. So number of successes. So here maybe you can have this infection data. This is infection, GN infection. This is GN no infection. This is pediatric surgeon's infection. This is pediatric surgeon no infection. And then you want to calculate the effect size. You have the options here. Here they have calculated the risk ratio. So we get that. And then that's all. We have to just submit. And so this is what we get. So it gives us the number of studies, and it gives the type of effect size, and it gives the standard errors and confidence intervals. And if you go to your data browser, you can see that new variables have been generated, which are the study number, the effect size, the standard error, lower confidence intervals, upper 95% confidence intervals, and the study size, right? So then next is you have to just do the forest plot. So you can just type in, first you can summarize the data. You can do meta summarize, and you can type the model, random effects model. And here Stata does it default by REML method. So you can just type that and you get the printout here. So here again, it gives you the numbers. You can see the command here, meta summarize, random REML. So you have the number of studies here. You have the I squared here. It is, how much is it? Okay, it's 0, right? What does that mean?
That there's no heterogeneity.
Yeah, right. So, okay. So to start with, usually what Stata recommends is you can start with a random effects model, but when you see that the assumptions for homogeneity are met, you can ultimately do a fixed effects model. So here you have the log of risk ratio, 95% confidence interval, weights. You have the test for homogeneity, which is, and you have the significance, and it's not significant here. Even the theta test, the test for homogeneity, I mean, it's like not significant. So you can generate a forest plot. So you can, same command like this. And you can get a forest plot, right? So what we had seen with the same data actually, right? So you can do a fixed effects model. So you can also go here and you can choose a fixed effects model here. Submit. Sometimes it takes a little time to come. So this is a command for this meta forest plot, fixed Mantel-Haenszel. And this is the fixed effects model. Could you guys generate it? If anybody wants to share the screen, and you can see here fixed effects Mantel-Haenszel model. So then you can, let's see what else we can do. You can do a cumulative meta-analysis also. We'll make a funnel plot first. We'll make a funnel plot. So you type meta. Just type meta funnel actually. So you can get your funnel plot here. You can do a trim and fill also. So here, if you just put trim fill, you won't get the funnel. So to get the funnel, you have to put. So what happened here? Anybody wants to comment? Is there heterogeneity? So since there's no heterogeneity, there's orange one dots would be the imputed studies. So since there's no heterogeneity here, there's no study or no publication bias. Also, there'll be no studies which have been imputed, right? It says one, but where is it?
Can I ask something, Mona?
Yeah, sure.
In the funnel, can you show again the funnel plot?
Yeah.
There's a study outside the funnel.
Yes, I'm looking for, I think it's covered by the video thing in my, yes, it is covered by the video in my, there is a study here outside and they have imputed one. It's, I don't know why it's not showing up on the panel plot. When you see the summary, it's showing that one study has been imputed. I was trying to show you that. Yeah.
It means it was removed?
Pardon?
What does it mean when it's outside the funnel plot?
Pardon?
I didn't understand why that study is outside. It's completely outside.
Outside. Okay, I'll tell you. I should was covered by the chat with. Okay, so you see here what it's again, as I said, the panel plot is what is it? It is nothing but a scatter plot. So this study here, which is in outside, it has the a high variance, right? That's why the variance is almost around very close to 1.5, little less than 1.5. And if you see on the x-axis, the log risk ratio is almost a little less than 3, right? So this is how it has been plotted. That is why, I mean, you can't change it. And this is lying outside the confidence intervals, means the variability is very high. In this study, it must have got a very small sample size, so it's getting a very high effect, a large effect.
So should we
which is outside?
Sorry. Should we make a sensitivity analysis?
See, in this, if you, I don't think this is due to publication bias, because here we are looking for publication bias, right? So we need not exclude it because when we look at the variance, it is not much. In fact, I square is very, very low. So it is not contributing. Since it's a small study, it would have got a smaller weight also. So it's not, dragging the effect size alone to a very abnormal position. So I feel we can include it, but then again, we need to look at it. It's probably got a very small sample size and a very high variability. You see the standard error is the highest in this study. And this would be what would they have imputed. I am not sure why it's not showing on the panel because in the graph it's saying that one study has been imputed. So it's a very small sample size, may not be contributing overall too much to the shift in the effect size. If you want, you can try and do a sensitivity analysis and see. I doubt it will cause much of a change in the overall results, so you can include it, right? And if you see the adjusted, there's not much difference between the observed and the observed plus imputed, effect size. They're 0.210 both ways. So it's imputed on the left, but it's not showing up in the panel. So then you want to do the sensitivity analysis. Let's see. Okay. So here I'll have to do it for this data. So you need to type in the data here. So this is the other variable. So for this variable, I'll do it. So this is just to show how it's done. This is all fictitious data. So this is just to show how it's done. And if you see, obviously you would exclude the study. This is probably number 5, right? Are you doing the exercise along with me and with data? Anybody wants to share their screen and show? And also you get a summary here. So did anyone try it? Anybody wants to share? You can also do a forest plot by subgroups. This is not the best example. I'll try something else. Yeah, so it's just I've just named the variable subgroup and divided into like 2. So you get 2 meta-analysis, 2 forest plots for the different subgroups, and you also get the interaction between the 2 subgroups. You should get. It's not showing up that, I think. Yeah, test of group differences. It's showing 0.52, and anyway, we know that this is there's very less heterogeneity, but just to see how it's done, you can just put that command and you can get it for these 2 subgroups, whichever you have defined, right? Maybe like duration less than 1 week, 2 week, or more than 1 week, or any subgroup which you have defined. Presence of hypertension, absence of hypertension, these 2 subgroups you want to see. So it gives the, again, similar forest plot with the confidence intervals and the diamond and the pooled effect, and the overall pooled effect also is there, right? And
I have a question. How do you interpret it there in that forest plot, the interaction?
yeah, this is fictitious data. How to interpret? I showed you in the earlier graph where we had the questions where you have to interpret the subgroups separately, and then if you want to see there is any difference, you have to look at the test of interaction, right? I have few more examples in my slides. I'll show you in those. That's authentic data.
Okay.
So I think we've made all the plots and the graphs, I think. So we should go back to the slides, I think. 1 second, I'll just go back to the slides.
Mona, can you share the command later? Because I found several students want to share it.
Yeah, which commands? All the commands?
All the command maybe.
They're in the slides in that.
Oh yeah,
yeah.
Yeah, we can download it your slide, so maybe a student
Yeah.
can find them.
Or I'll type it in the end. If you see here, these are the basic slide commands here. Except for the sensitivity analysis, I'll type it in the chat. Or this is all the basic commands you will need. You can build up on them, like comma, random. If you want, I can type it in the chat and put all the commands there. No issue.
Yeah, I think we can find it. We can find it from your slide later.
Sure.
Yeah.
Sure. Okay, so this is just basically, anybody wants to comment on what is subgroup analysis? I think that's a few questions on that, and then I think we finish. So what is subgroup analysis? And we've already done some subgroup analysis. That was in meta-analysis, but you can even do it in RCTs. So what are they and why would you want to do them?
Hello?
Yeah, can you see?
I think this subgroup analysis, this is Iman. I think subgroup analysis, when we want to check if one of the baseline, I know it for the randomized, but I'm not sure about the meta-analysis one, if there is one of the baseline characters has impact on the results. So we run this subgroup analysis and we can check if more than, for example, if one of the subgroups has effect on the outcome, so we can test if more than one of the subgroups has effect on each other. That's why we can check for the interaction between each others and check how that impacts the final results.
Okay, so why do you want to check this?
To make sure that if we are testing an intervention on the effect of the intervention on the final outcome, so to make sure that our conclusion is robust, that the intervention is the cause for the change in the outcome, and if these subgroups has effect on the final outcome, this is something. The other issue is if some subgroups of our population are responding in a different way than the others to our intervention.
Yes. So what we are studying in a RCT is just a mean, like, we've, as you've seen, we just, or in a meta-analysis, we just calculated a overall pooled effect, right? So, but we are seeing a patient in a clinic. It may not apply to that patient. So sometimes, in some groups, as you said, it may be having no effect or a better effect or even a harm. So you do a subgroup analysis to look for that. So anybody wants to answer this question? Want to select the incorrect statement? Which is incorrect. A is correct. Subgroup analysis is performed to confirm a pre-specified hypothesis. I mean, do you do subgroup analysis once you finish your study, or do you plan it ahead, which is a better option?
It's better to plan it while making the protocol for the study. So
yeah, that's so A is correct, right? This statement is correct, right? Pre-specified hypothesis, a priori.
Maybe because I don't see the screen I don't see your screen.
You're not seeing my screen?
I think it's a problem with my computer. It's not yours.
Oh, okay. Okay. So the second statement is subgroup analysis is performed to generate a new hypothesis. Is that true?
Generate hypothesis, yes.
Yes. Why? Because once you see a difference in a subgroup, then you can maybe plan your next RCT based on that also. You can test that hypothesis, right? Subgroup analysis should be performed when the results of an RCT are negative. Is that correct?
Mona, sorry to interrupt. You're not sharing your screen.
Really? You can't see?
No, we can't
So
see
it is
them.
not my computer.
Now?
Now we can see. Thank you.
Yeah, so you can see it, right?
Yes.
So we were talking about statement C, subgroup analysis should be performed when the results are negative. Do you think it is right?
I think it is not summative for the subgroup analysis.
It is?
I think not necessarily correct, because we can do subgroup analysis even if we find positive results. We want to analyze if it's true for different groups, like older people or
So what
any
is trying
other
to say,
baseline.
suppose you do your RCT and you don't get anything positive, then you think, oh, let me do some subgroup analysis and see. Is that a good option?
No, I don't agree.
Yes.
I think we
So,
have to decide previously, so we don't know yet the
whether
results.
it's positive or negative, they have to be decided beforehand. It's always a better option. So is it based on the pre-randomization characteristics?
Yes.
Yes, because if it is post-randomization, the treatment itself may change the characteristics, right? So then null findings in a subgroup suggest that the intervention has no effect in a subgroup. Is that true? We just saw it in one of the questions earlier.
No, maybe we don't have enough power to say
Yes,
that.
very good, yeah. And a positive finding in a subgroup needs to be interpreted in context with full and other subgroup results. Is that true?
Yes.
Yes, it's true. Right, very good. So, yes. So like we just said, perils of subgroup analysis, like you said, it can be false negative, it can be a false positive, it can break the randomization, because initially the participants were randomized for the main comparison. When we are comparing subgroups, you're actually breaking the randomization. So that's why you can get all these errors. So this is a clinical scenario. You are sitting in the emergency room and there's a patient with symptomatic carotid artery disease with more than 70% stenosis, and you've read now that there is a subgroup analysis, and on the basis of that you want to decide whether you want to treat the patient medically or you want to take up for surgery. So this was a subgroup analysis, this was the subgroups. So suppose your patient is falling in subgroup A. Will you do surgery or based on this subgroup analysis, or will you go for medical treatment?
Surgery.
Huh?
I think I would do surgery.
You would do surgery, okay. Now what if I tell you the groups were based on the month of birth? You would still go for that? The analysis for subgroup was just based on when the patient was born. That was the basis of the subgroups. Would you still go for surgery?
I think so, because the main result goes for surgery, if I understood
Is it
correctly.
biologically plausible? Is it biologically plausible?
Not because of the month, but because of the main result of the meta-analysis that favors
No, this is not the main result. This is the subgroup. This is not the main result. This is the subgroup.
There is no explanation
For each
for
subgroup. This is for each subgroup.
Yeah, but we don't have the diamond in the bottom is not the main. I thought it was the main result. No, the subgroup with
It is
each
the main
line.
result of the sub. Then the subgroup doesn't matter. Then you would anyway do surgery, right? Then
Yeah,
why would subgroup?
that's what I meant. Yeah, that's what I
No.
understood.
No, that's what the perils of subgroup analysis are. So here all of the groups are based on the month of their birth, and so this comparison may not be correct actually, because of the participants may be unequal, small sample sizes. So the results, whatever we just discussed, the same applies here. You have type 1, type 2 errors. You don't know, right? So you need to confirm the subgroup analysis and not base your decision on that. So if you did the same subgroup analysis on the same patients based on the day they presented to the hospital, suppose, then you're getting something else totally. And another thing which is there is that there is no interaction. The term for interaction is not significant. So you don't need to look at each subgroup. You need to see whether the subgroup treatment effect interaction is significant or not. Like whether one subgroup is different from the other. So we already discussed the Bonferroni test earlier, and the other is the test of interaction, which we should look for. This example, I think, will make it more clear. So if you see here, they did hormone replacement therapy for prevention of fractures, and they did a meta-analysis, and for all trials, they found the effect estimate to be 0.73, right? They had 8 trials, and then they did a subgroup analysis for women less than 60 and more than 60. And the difference was coming significant in women less than 60, whereas more than 60, it was not coming significant. So they concluded that the treatment was good for younger women, but not for those more than 60 years of age. Do you think it is right? So here again, please tell me.
I think that we made a conclusion that subgroup analysis for hypothesis generation and not for clinical decision taking. But if we have to take a decision here, I think we can accept something like that if we are linking it to a certain reason or an explanation, right?
Okay. So again, what is missing here is first is a statistical test. There's no test for interaction. So here they're just comparing within the less than 60 years group, what was the difference between those who received the hormone replacement therapy versus who didn't. So, and for that, the p-value is 0.06. So this is within the group, within that subgroup. So women less than 60, you're comparing them with each other. Here you're comparing women more than 60 with each other. This is within the same group. If we want to see that there is a difference between the two subgroups, we have to look at the difference between 0.67 and 0.88. This should be different to say that yes, there is a difference between women less than 60 and women more than 60 receiving the therapy, right? This 0.22 could just be because they've not mentioned the number of patients who were more than 60. It could be because of a low power. You never know, isn't it? So you can't say the treatment was not effective in these. That is one issue. And secondly, to say that there is a difference between women between 60, less than 60 and more than 60, you have to compare the two subgroups with each other. That is 0.67 with 0.8. Right, that is the statistical test for subgroup analysis. Otherwise, you can end up, if you just see the p-values, you can end up with misleading conclusions, right? And plus, as you said, that this could be a future hypothesis which we can look at and not, just explore it further in another trial, and maybe not base our decision on this, because this was never the primary outcome, right? So if you see the next slide here, the interaction test was not significant. So actually there was no difference between the two groups. So this is a very important concept in subgroup analysis. It's very easy to see that, oh, the p-value, of the two groups, and say, oh, this is significant. So in this group, the treatment is working, whereas in the other, the p-value is not significant. But you're not comparing the groups with each other. You're comparing among themselves, right? And getting a p-value, and which, because you have made a subgroup, you have less patients, less power. It may be type 2 error also, right? Are you getting the concept?
May I ask a question here?
Yeah, please.
If we are saying there is no interaction, that means subgroups are not affecting each other, right? Or
no, the
there is
statistical
no interaction, that
test
means there is
for
no difference.
interaction means age is not an influence on the I'll just come to the next slide, you'll come to know. So here you can take the effect of HRT instead of BP. So you have gender and treatment, like you could have had age less than 60, more than 60, and treatment, right? So this is a statistical test you do for interaction. So here you're seeing whether there is an effect of age on the treatment. And here you're getting a p-value which is 0.2, which is not significant. If this was significant, then you can believe it, that okay, this 0.67 and 0.88, the difference is statistically significant among these two values. But if the test of interaction comes not significant, then it could be just due to chance. So you have to do the test of interaction between that, whether age is affecting the treatment or not. Did I make myself a little clear? I know it's a tricky concept to understand. Took me a while to understand it also. So if you have ANOVA, you have HR, whatever value you want here, your dependent variable, and then you have, the one which you want to check the interaction with the treatment, gender, or here it's in female, so it will be age. You have categorized it less than 60 and more than 60 and treatment. And then you see what the p-value you get. If it's significant, then yes, the age has an effect on treatment, which indirectly means that the treatment is effective in one age group and it's not effective in the other age group. If your p-value is not significant, then you cannot say that, the treatment works better in one age group as compared to the other. You get my point?
Yes, thank you.
Okay. So finally, to decide the results are credible, I'm sure you've already read this. It should be, a priori, and even the direction should be specified a priori, and you shouldn't have too many subgroups, and you should have analysis is very important. Many studies miss this. The interaction test should be done. I think it's in your assignment also. So that was the command actually. So you can use it. It's a shortcut command actually. The one in your assignment has ANOVA, BP, gender, and then gender interaction with treatment. This hash is one. This is a shortcut. If you just type this, it's equal to the same command. So it's kind of a shortcut here. So, and again, is the subgroup effect very large? And another important thing is it consistent across studies? Now with the one which I'll just show you another example for that. And is there biological rationale, right? So this is a mnemonic which you can remember, plausible, pre-specified, a priori, consistent, confidence intervals, are they overlapping or not, context. It should be replicable, which is very important. Like we saw the one with the day of the month of birth, and then we made another subgroup with the day they presented to the hospital. You see how different the forest plots were. And whereas this is another one, the same one where they had the month of birth, and they compared it across the two groups with more than 70% stenosis and less than 70% stenosis. And you can see how variable the forest plots for each subgroup are. It is not replicable across, more than 70% stenosis and less than 70% stenosis. So whereas in this case where, they did a trial which was based on when the patient presented for randomization from the last event to randomization. It's a more biologically plausible thing to make a subgroup on, like when the patient presented with the event more than 2 weeks, 2 to 4 weeks, 4 to 12 weeks, and more than 12 weeks. And you can see the similar trend across the various subgroups. And in the same trial and in a different trial also, if we take weeks from event to randomization, it was kind of replicable. So it's very important whenever you're getting a large subgroup effect, you should be able to replicate it across either different levels of the same variable. Like here they took more than 70%, less than 70% of stenosis. Or in different trials also, this should be replicable. So I think it's been a long lecture now. So basically, I just feel you should just read and explore Stata a lot, because there are a lot of commands. Especially you can open up the graphic box and try out all the commands on the data set, and just get a hang of how to do the analysis, make the forest plots, and change the graphs. You can add on to the commands. In the Stata manual, it very nicely gives you how to plot the various line of no effect and change the column titles, everything, change the color, plot the center dots. There are many options which are available, so you can explore that. And if you have any questions, please let me know.
Excellent presentation, Mona. Congratulations. Thank you.
I hope it was useful for you.
Thank you, Mona.
Thank you.
Actually, I found a similar question from chat, but maybe you already answered, or if I can find more, maybe I can send you an email. And
Sure,
also,
sure.
maybe student can send the question to you. Yeah.
Please do. Please.
Yes. Thank you so much.
Okay. I'll send you the commands. Maybe you can pass it on to the.
Right. That's great.
Once I can pass it on.
That's great. Thank you, Mona. Very instructive, very interactive lectures.